Hello students, welcome. Myself Dr. Roshni, your OBGYN faculty at DigiNerve. So today we are going to deal about the INI-CET exam. This is the last minute pulse since our INI-CET is round the corner and everybody is preparing for that. Let us do some quick revision of the high yield topics only. So this is what you have to read in your last minute or recall in your last minute. So to begin with, hypertension in pregnancy, yes, this is one of the commonly asked and almost there in every paper. Mind it, every paper there is one question from this topic. So to begin with the types, as we know, hypertension in pregnancy is classified. Firstly, your pre-eclampsia, then comes your gestational hypertension, then comes your eclampsia, then comes your superimposed, and lastly, chronic hypertension. So the first and commonest thing is BP of more than 140/90, isn't it? More than 140/90. Coming to pre-eclampsia, here it is after 20 weeks period of gestation associated with proteinuria bar end organ damage. So either proteinuria or end organ damage is seen in pre-eclampsia. And in gestational hypertension, here also it is after 20 weeks, but no proteinuria. There is no proteinuria or any end organ damage. Remember, both in preeclampsia or gestational hypertension, the BP should come back to normal within 12 weeks of delivery. By 12 weeks, it should come back to normal. If not, it is a case of chronic hypertension. Coming to eclampsia, any of these associated with seizures, then it is a case of a eclampsia. Coming to superimposed pre-eclampsia, here a person who's already hypertensive becomes pregnant. Now that hypertension is superimposed by pre-eclampsia. So how will we recognize? Yes, they will give you a history, known case of hypertension, something history like that. Then how will you recognize superimposed pre-eclampsia? Yes, if the BP is worsening, not getting controlled by the initial medications, or the proteinuria, initially it was no proteinuria, now she has proteinuria, or initially there was 1+, now she is having 3+, or there is end organ damage that is developed after 20 weeks, that means it is a case of superimposed pre-eclampsia. Finally, chronic hypertension is, that is, the pregnant lady is known case of hypertension, or even after 12 weeks of delivery, the BP did not come back to normal. A known case of hypertension, or even after 12 weeks of delivery, she is still having a hypertension, then she is a case of chronic hypertension. Remember, that is very important to know the diagnosis because they will give you a history and ask for the diagnosis. Next, coming to pathophysiology, as we all know, the basic pathophysiology is the second wave trophoblastic invasion, isn't it? The trophoblastic invasion would not happen in preeclampsia. So here what will happen? Your radial arteries, spiral arteries and the basal arteries. So here the tunica media, which is having smooth muscles, will get replaced by loose areolar tissue, making it a high flow, low resistance. That means the flow is high but the resistance is low, which is normal. It should have happened. Since it is not happening in preeclampsia, it will become high resistance and low flow. So here there is increased resistance. It is low flow. The blood flow to the fetus is becoming small, less. That is why there is increased pressure from the maternal side to push the blood towards the fetus, isn't it? So high flow, high resistance, low flow in preeclampsia. This is also very important, a must know thing. And next, the other pathophysiologies are your free radicals are increased, your angiogenic factors, that means new vascular developing factors is reduced, whereas anti-angiogenic factors are increased. And thirdly, your vasodilators. So vasodilators like prostacyclins have been reduced, whereas vasoconstrictors like thromboxane is increased in case of preeclampsia. So these are the other things like nitric oxide and all is becomes reduced. And one more important thing or names that you have to remember is about the soluble FMS like tyrosine kinase. Okay, this is one thing, and soluble endoglins. These are the anti-angiogenic factors. Anti-angiogenic factors which are increased in preeclampsia. These are commonly asked questions. That is why I'm specifying these names. Okay, so you should know this. Next, coming to diagnosis, as we know, it is by the examination, BP, the readings that you have taken. Associated with, you should also in physical examination look for pedal edema. Preeclampsia patients usually have pedal edema. Okay, grade 1 is up to ankle, grade 2 is up to knee, above knee is grade 3, generalized is grade 4. Okay, grading also you should know. And lastly, Lastly, coming for examination on per abdomen, you can see IUGR, small baby, or the growth is not appropriate to the fetus. I mean, if she might be 32 weeker per abdomen, just 28 weeks pregnant uterus is there, like that growth will be having disparity. IUGR or oligohydramnios may be there. Okay, these are the other things that you should notice. Other than this, in history wise, what are the alarming signs? So alarming signs that they mention in your history are coming to headache. Okay, headache, blurring of vision, epigastric pain, and vomiting. So these are called imminent signs. Any patient come with these complaint, then you should treat as severe preeclampsia or impending eclampsia. If you do not treat her now, she will end up having eclampsia. So if they've given you a history suggesting with all the clinical symptoms of impending eclampsia, then your management should be like eclampsia. You should start giving magnesium sulfate. Okay, that is why I'm specifically telling, whenever in your history if they have mentioned alarming signs, then you should manage it as eclampsia. Okay, now coming to treatment. Treatment is basically depending upon the gestational age and the complaints. Okay, so if she is preterm, well controlled, no complaints, then you can carry out as a OPD basis BP monitoring. If she has complaints, then you have to admit her. If she is preterm, you will steroid her. If she is term, you will terminate her. Remember, the treatment for preeclampsia is termination of pregnancy, not cesarean section. Is termination of pregnancy. You should take a risk and benefit. So for example, if she's preterm, you steroid, you have a time of 48 hours, you steroid, and then you terminate. If she's extremely sick, she's already having eclampsia, she's throwing a seizure, then you terminate immediately. That is how you decide. Okay, now coming to the options that you treat on OPD basis, you give either tab labetalol or you give tab nifedipine, the calcium channel blockers. Okay, and in case of IP patients or severe preeclampsia where you want immediate control, you can give these two also, but labetalol will become injection labetalol, that you will give at 20, 40, 80, 80 mg. Okay, this is how you give. You give initially 20 mg, then if after 15 minutes it's not control, 40 mg still not control, 80 mg still not control, another 80 mg, total of up to 300 can be given. Now it is increased to 330 milligram. Then tab nifedipine also can be given. These calcium channel blockers also will reduce BP abruptly. Okay, one of the complication is sudden hypotension also. Okay, so nifedipine also can be given. Other than this, you can use hydralazine or you can even use sodium nitroglyceride patches also. So this is how you manage for hypertension. Next, coming to eclampsia. So anybody with seizures is called eclampsia. Remember, seizures unless otherwise ruled out is always eclampsia. If she is a known case of seizure disorder on Levipil, then you can consider as seizures. Otherwise, any patient throwing a fits is always a case of eclampsia unless otherwise ruled out. So in eclampsia, how will you treat? You will treat with magnesium sulfate. So what are the options that you have? You have IV regimen and IM regimen. IV regimen is your Zuspan regimen. This is used with a drip monitoring. So infusion pump should be there. The drip monitoring should be there. And also it is used in case where thrombocytopenia is there. That means there is low platelet count. If you give an IM injection, she might end up having a hematoma, isn't it? So you can use IV regimens here. So in IV regimen, what you'll give? 4 grams IV loading dose over 20 minutes, followed by 1 to 2 grams of per hour infusion of magnesium sulfate. This is your Zuspan. Coming to Pritchard's, the commonly asked. So in Pritchard's regimens, what happens? You give loading dose and maintenance dose. So what is the loading dose amount? It is 14 grams. Please remember, it is not 4 grams. This is commonly confused. Okay, so it is not 4 grams, it is 14 grams. In that, 4 grams is IV and 10 grams is IM. That too on each butter, 5 grams each. Afterwards, maintenance will be 5 grams every 4th hourly. You should be giving it. Okay, that is how you will give magnesium sulfate. This is by your Pritchard's regimen. Please remember the name, route, and also the dosage. It is commonly asked. Okay, this 14 grams and this 5 grams, and this maintenance 5 grams every 4th hourly. Till when you should give? Till 24 hours post seizures or a delivery, whichever is later. Okay, till then you have to give your magnesium sulfate. Next, coming to magnesium sulfate, since we are giving so much, we should know about it very clearly. So magnesium sulfate has a very small therapeutic range. Even if it goes little high, there is chance of having magnesium sulfate toxicity. 4 to 8 milliequivalents is the magnesium sulfate normal therapeutic range. Anything more than this can end up having a magnesium sulfate toxicity. Like more than 8 can start developing loss of deep tendon reflexes, and more than 10 can have respiratory depression, and more than 15 can end up having a cardiac arrest. Okay, so this is what you should remember. That is why magnesium sulfate is always monitored. So how will you monitor it? Firstly, by urine output. So it should be at least 30 ml per hour. For example, in your history, they have given you a history where urine output is just 15 ml per hour. The next maintenance dose should not be given. You should withhold the dose. Okay, that is why it should be 30 ml per hour. That is when magnesium sulfate is excreted, so you can give your next dose. Then comes your deep tendon reflexes. You'll check for the knee reflex. Okay, so knee reflex should be positive for you to give next dose. If not, you should not give. Then comes your respiratory rate. At least 14 to 16 cycles per minute should be there. Then only you can give your next dose. Okay, because respiratory depression is common if the dose is increased. So this is how you monitor. Okay, whatever you have said and done monitored, still the patient ended up having a case of magnesium sulfate toxicity. How will you treat her? The antidote is calcium gluconate. So how much calcium gluconate will you be giving? It is 10 grams, 10% dilution in 10 minutes. Okay, you can remember as 10. So 10 grams, 10% dilution in 10 minutes. Next, coming to magnesium sulfate mechanism of action. I have written down this because please read this. This is also commonly asked question. Why? It is used so in and out, so you should know its mechanism of action. So basically it stabilizes the membrane. So membrane stabilizer and neuroprotector. It acts by end plate. Motor end plate sensitivity to acetylcholine will be reduced. Okay, it will be reduced. And magnesium also blocks neurotransmitter. The calcium channel influx will be blocked, and decreased presynaptic release of neurotransmitters. Okay, so presynaptically the neurotransmitters are released less, so that the next movement will not happen. The next nerve is not getting stimulated, and then the movements would not happen. Presynaptic release of neurotransmitter glutamate, and it blockage of your NMDA receptors. Okay, these are the common mechanisms, and you should know all of this because they commonly ask all of them are the mechanism of action of magnesium sulfate, except such questions are pretty common. That is why I've written down this. I hope you read this. Now let us end this with some of the MCQs. To begin with, which of the following is not true regarding etiopathogenesis of preeclampsia? Endothelial dysfunction due to oxidative stress and inflammatory mediators. Yes, we told oxidative stress is there. Free radicals are there. So this is correct, not true. There is decrease in the levels of nitric oxide and increase in angiotensin 2 levels, and levels leading to development of vasospasm. Yes, there nitric oxide is a vasodilator. So it is decreased in preeclampsia. So this is also true. Increase in anti-angiogenic factors like FMS, like tyrosine kinase, and decrease in your angiogenic factors. So this is also true. In preeclampsia, there is increase in prostaglandin I2. This is a vasodilator. Will it increase? No, it will decrease. And decrease in thromboxane A2. Thromboxane A2 is a vasoconstrictor. Will it decrease? No, it will increase in preeclampsia. The not true will be answer D. Next question. A 25-year-old primary gravida at 24 weeks of gestation is evaluated for first time, and her blood pressure is noted to be 140 by 88 and 144 by 90 even after 4 hours apart. When she is evaluated 15 weeks postpartum, that is after 15 weeks, remember this, and her blood pressure was still said to be high. Okay, measured 4 hour, urine output was 2 grams for 0.2 grams for 24 hours. So what is she a case of? Yes, even after 12 weeks, it doesn't come back to normal, then everybody will be labeled as a case of chronic hypertension, isn't it? So this is your correct answer. Next question. All of these are indicators of severe preeclampsia except thrombocytopenia. Yes, it is severe preeclampsia. Pulmonary edema, yes. Complete blindness. Your papillary edema can lead to complete blindness. So this is also correct. Low serum transaminase level. So your ASLT will be reduced. No, there is deranged LFT. Your ASLT will be raised, isn't it? So this will be your correct answer. Next question, which of the following is the best predictor of preeclampsia or PIH? So remember, there are many other methods for detection of preeclampsia or prediction of preeclampsia, but only proven method is by your Doppler, and that too uterine artery Dopplers. Okay, uterine artery, your second option, is the only proven method. The other methods are like your uric acid levels or your serum calcium levels, many other folic acid levels, many other things have been in testing process, but the only proven method is your uterine artery Dopplers. When you do your early scans, they'll say screen positive for Doppler, screen positive for PIH, then you should suspect she's going to develop preeclampsia, and you can start on what? Yes, you can start on echosprin 150 milligrams.